Well, when I interviewed you, Dr. Westman, I pointed out that you had brought up addiction in the book, like very early on in the book. And you had said, if one bite is too much, don't eat it. And there's very few medical people that really understand that. And I can tell you, I just want to tell you, my husband's a cardiologist and he recommends your book with Amy above any other book because people can understand it. So number one, thank you for that and for doing the work you're doing and for understanding that, one bite is too many for some people of some things. And I think you included things that people think are healthy too, because it's not healthy for you if you have no breaks. So I'd like to hear you talk about that, your experience with helping people, your experience with, addiction in general, because you did run a smoking cessation clinic and all of that. So, why do you tell people to stop eating things they can't control or manage?
Sure. Yeah. So my first career really was for 10 years working as a nicotine expert. I got to work with the inventor of the nicotine patch here at Duke. And we helped to do some of the early studies that actually separated out the sensory characteristics of cigarette smoke from the nicotine. So I'm one of the few people who's actually infused nicotine in someone's vein.
Wow.
How crazy is that? So I'm an internist, but then worked with a PhD scientist who said, Eric, let's put nicotine in people's veins. I'm like, well, okay. So I learned how to do that and got an anesthesiologist involved and all that. But so what we learned early on, and what was pretty clear to my colleague in terms of smoking, is that there's a big difference between the drug nicotine and then the whole behavioral components, the smoke, the hand-mouth stimulation, the oral fixation. So when I then went to my general medical clinic and started helping people fix the problems that they were having, the diabetes, the extra weight, I had no tools. As an internist, even today, you're not trained to help people lose weight. You're not trained to know what proper nutrition is. So I really had to kind of, from the beginning, reset what I was thinking, and a couple of my patients did a low-carb, high-fat diet, an Atkins type diet. And so I started just learning, and my approach is to go to the expert, So I wrote Dr. Atkins a letter, and he called back, and next thing I know, I'm in his office seeing patients with him in New York City, and it clearly could work, but was it safe? So we embarked on a bunch of studies looking at high-fat diets about the safety of it. And now through the lens of 20 years of research and clinical care, changing the food so that you don't eat junk is safe. And that's what a low-carb diet is. So, how you, whatever you call it, you might get a trigger even today. Don't tell your doctor you're doing an Atkins diet. They'll freak out. And don't say you're doing a keto diet. They'll freak out. Say you're doing a Mediterranean diet. And they won't know what it is, but they've heard that it's good. So they'll go, okay, that's fine. But so it became very clear to me that there were, and my own experience as someone having Halloween candy the size of a mountain and bartering with my brothers on our favorite candies, that we were all just really kind of sharing drugs and sugar. It's very easy for me to wrap my head around nicotine as a drug that is commonly accepted by the medical world, and also sugar as a drug because the behaviors were the same or very similar. So then people will say, oh, but you can't have a sugar addiction or a food addiction, you have to eat. Well, but you don't have to eat junk, right? That should be pretty clear to you. So that was clear to me. And so the sensory cues, the hand to mouth, the behavioral elements still apply to food. And if you infused glucose or fatty acids into the vein, you wouldn't have the sensory feel of the sweets and the food and all that. So it's complicated. I feel good because I know there's a cigarette in my house when I wake up in the morning. It's similar to I feel fine going to bed because I know there's my sweets in the cupboard that they'll be there in the morning. So when you're starting to even going that far to make sure you have certain foods around, this is clearly addictive for some people. Now, so this is the darndest thing. Probably most cardiologists never had severe sugar addiction, so they're not going to be aware of it, right? And so you can't always rely on the top down to understand it. So sugar addiction or processed food addiction, with sugar being the main component, and is certainly real, and it varies in different ways. It expresses itself differently. And so the most common way to give up an addictive drug, especially something like tobacco, is called cold turkey. You stop the drug, you go through a withdrawal, you might have some cravings. Let me tell you, it's easier to quit sugar than it is for most people than it is to quit smoking. And even then, this is now what, 20, 40 years into the war against tobacco, and there's still like 15% of Americans who smoke. So there's always going to be people eating sugar, even if the awareness comes up that it's an addiction and you need to be very careful about it. But it still is not understood that way by most doctors, like you mentioned. In fact, I've had a couple lives with Dr. Vera Tarman, who wrote Food Junkies and has a podcast, and she was on with our Adapter Life membership, which is my company to try to get this information out to more people beyond Duke. And she mentioned something that just resonated. It was really helpful for me. She said, the difference between binge eating classically is that it was a brain problem. It was an emotional problem, and you handled food to soothe the brain. And so what you really need to do is have therapy to fix whatever the emotional problem is. When you come at it from a sugar addiction point of view, it's a food problem. You get rid of the addictive substance, there's no longer an issue, So that makes so much sense to me. And this is exactly what I was trying to find in terms of our treatment of diabetes. So endocrinologists don't think food is the problem, so they give you drugs. And they might even give you drugs that make you gain weight, which make you eat more, which compounds the problem. But because they don't see food as the initial problem, they just give more drugs. It got to such a point in this one patient I had, she came off 600 units of insulin in 3 weeks. And her story actually was such that she came into my office and saw the list of food on the wall. I basically have the chart on the wall. And she said, I'm not doing that. There's no way. And so she left the office. I called the next week. We just started a pilot program. And I said, Shelley, what if we bring you food on Saturdays, to get you started? And so we did an 8-week food delivery program and about 20 people as a pilot. And she said, well, yeah, if you're going to bring me food. So basically, we didn't bring bread, right, and fruits and vegetables. We brought meats. We brought lightly expired frozen meats, a little bit of vegetables, and then some pork rinds. And the students actually involved got snookered by some vegan pork rinds that are made out of rice. They didn't look carefully on the label, and I saw the food bags. I said, what's this? It's porkless pork rinds. It was actually pork rinds made out of rice. Oh, God. So too high in carbs. We didn't let those go through. But so she started doing the diet on her own, and then her husband started doing it. She watched her blood sugars at home. She had a continuous glucose monitor, was capable of her own self-adjustment down. Before we know it, she's off all of her 600 units of insulin in 3 weeks. And now, or since last summer, she's lost over 80 pounds, and the family's lost weight. And so it's all about the food. But if the diabetologists and the endocrinologists don't think it's about food, it's some abnormality in the cell. And if we only just give them medicine to fix that abnormality, we can fix it. Well, no, they just manage it. So anyway, I was talking to Dr. Tarman. The difference between binge eating, the classically understood, and addiction is the treatment. The treatment is driven by your understanding of the cause. And so the reason we treat people differently than endocrinologists for diabetes is we don't believe you just manage it with drugs. We believe you, and we know you reverse it by addressing the food. And in fact, with Dr. Tarman, we were chatting. We think it was her impression that the strongest sugar addicts develop diabetes, and the strongest sugar addicts end up having weight loss surgery. And of course, there are a few surgeons who are onto this. Dr. Rob Siwas is a popular YouTuber, but also a clinical doctor in Florida and a surgeon. But most doctors most surgeons just really think that they're fixing things by making the stomach smaller or rerouting things, when really it's just managing it. And if you don't ever really address the food component, the carbs, the weight just comes back, unfortunately, for most people. So I guess my training in addiction, I never went to addiction medicine meetings. I went to the Society for Research on Nicotine and Tobacco. By that time, this group had splintered off into their own sort of tobacco, because even then the addiction medicine has a certain belief system based more on alcoholism and other drugs, and smoking is legal. You can, it's easy to get, and now I wish sugar and carbs smelled bad, because then at least we'd have the former smokers hate cigarette smoke. Can you imagine? I don't know if you've had that experience. I haven't. Whenever I go into a room where there's popcorn popping, I think it still smells great, even though I really haven't had it for 20 years. I wish there was a switch so that the smell of carbs would suddenly be bad. But so I guess I was set up to really kind of see the behaviors, and the solution is to take away the addictive substance. And trigger foods are the language we use for a food that triggers your hunger, or makes it so you can't stop eating it. Nuts being the classic ones. And so I'm very open about that. At first, I don't let people have nuts. No nut flour, no nut butters, and often that's the only thing that needs to change to get what they've learned on the internet today to something that really works. Talking to Dr. Tarman, they had a sugar and carb program, but it's no longer funded. So they're actually bringing people in and treating them. And we sort of had that approach here in Durham, owned by Duke. There was the Duke Diet and Fitness Center. They closed last year because of COVID. And I don't know that they're going to open again, but that's kind of the way classically we've treated sugar addicts, is they travel, if they have the money, to a safe place where they get food that, no one, I don't know of any program that really talks about sugar addiction directly, but essentially that's what they were doing, is giving food that didn't have sugar under a lifestyle kind of program. When the Duke Diet and Fitness Center closed, it was about $2,500 a week to stay there. So it's a little cost prohibitive for the average patient of mine. So there is still one weight loss and lifestyle program in Durham. It's called the Structure House. And so if someone says to you, you would have to lock me up to get me off sugar. I know a place just right across town here. Again, it's I think $2,500 a week to check in. But one of the brilliant things about Structure House is that the residence is right on the same property. So you drive onto the property, the apartments are in the back. You walk up to the building where the restaurant is, the dining area, and the gym, that sort of thing. So if you really want, you can just stay there and keep it like a safe haven. Some of these other programs, people would be driving to the center and then stopping at KFC on the way home. They're getting a big pizza, and because it's addiction, and you don't have control over it. Okay, switching gears. Today I'm in clinic, and the shame, the guilt, the I'm not worthy that people come in here with, it's just I don't know the right word. It's sad, and it's because of because the general society, doctors as well, have always blamed people for programs not working, and taking the history of this person who was 67 years old and she never found anything that worked. And I looked up the wall and said, have you ever tried a low carb diet? And she said, well, yeah, I did Atkins, 20 years ago. It really worked well. And so anyway, there was just kind of a 20-year period when, so I got her basically on the Atkins induction kind of diet, which is sugar-free, it's gluten-free, it's additive, like preservative and dye-free if you use a real food-based kind of program. But and so this person had never really thought through the idea that she was a sugar addict. So, and then another person today, a guy, which I think matters a little bit, he came in and basically said, I'm a carbaholic, I know it. I said, well, okay, then why are you eating carbs? So there's a difference between understanding it and then implementing it. And one message that Dr. Tarman left with our group recently is that you really need support. With any sort of addictive substance, there's going to be relapse. There's going to be a time when you just need someone else to turn to who's been there, can help you through it. And then that's why a lot of programs will include the idea that you become a mentor to someone else. And I'm even wondering, maybe we should do that more formally with our group, to just pair people up and with people's permission, of course, but because then it just lowers the bar for communication for people to reach out. Even on Facebook, which is relatively anonymous, there are a lot of people who are shy and won't ever even just type their things in, even though they're no one. I mean, that might be 1,000 miles away from somebody else. There's still this in our generation, this reluctance to do that. With my kids, I mean, if they don't put it on Instagram, it didn't happen, right? But yeah, well, so that's kind of, I'm still in a clinic here at Duke from Tuesday through Fridays, and seeing a lot of new people, and now the word's out kind of that I can help people with serious medical problems. So I see a lot of people with heart failure. They might be on the transplant list. One of my patients recently told her story at one of our conferences we put on, and she fixed her heart failure basically with echocardiographic, echo is like ultrasound of the heart, proof that her heart was squeezing about 20% and it's supposed to be 55%. And yes, she lost 120 pounds, but basically her heart failure is gone now, and she's doing things that she thought she could never do. So don't forget that the medically the effects can be medically impactful. So it's not just well, I suppose any drug of abuse or that can lead to addiction, alcohol, smoking, have some downside, right? But the rock bottom for sugar addiction actually might never occur, because it tastes so good and all that. Well, I wonder, is this a good forum for questions?
You bet.
Yeah, I'm happy to. I was just talking about what's on my mind. When I got on, I saw. Did you show a clip from our interview before?
Yes.
Yeah. Okay.
Yeah, and I guess I have one question real quick, and then we can open it up for Donna. But my question is, what have you seen over the years, maybe when you didn't realize that sugar was so addictive? Like, have you seen people enter that slippery slope early on in your career with helping people with changing their diet and looking towards the medical aspects of it? Have you then seen patients years later that were obese again or back in the food and that kind of thing?
Yeah.
Because that to me that was heartbreaking to me as a coach, and I like working specifically with sugar addicts now, because I think we're dealing with the real underlying issue rather than just a diet.
Absolutely. And so relapse is common, and it's more the norm, and you just have to keep at it. There was the old saying that it took about 7 times for people to quit smoking for it to stick. I think it's something like that probably for carb addicts as well, before it's done. Suddenly you wake up and say, yeah, no, I can't really have that again. But I think it's really helpful to have someone, a coach or a therapist, someone to a food addiction specialist to point it out, to just go through, well, what happened, the holidays happened, and well, no, what happened? Well, so-and-so came to town. I said, no, what happened? Okay, I had cake. There's all that sort of evading, and just having someone to bounce that off can be really helpful. So I'll see people who this year, for example, or this week, I had met for the first time in 2015, and then lost about 50 pounds. And she was gone for a few years. I just didn't see her, and then came back and gained 50 pounds and was back. And so there's something about her, the alarm that goes off at about 50 pounds, and then she's back in my office, kind of like this. So we had a really good discussion with Dr. Tarman about artificial or non-sugar sweeteners. And it's really kind of a mixed bag, because for some people, I need them to get them off sugar, at least temporarily. But the goal is to get people off that stuff eventually. Otherwise, you'll end up going back to sweet things. I'm not sure how your experience has been there, but I'm pretty allowing for the use of non-sugar sweeteners at first. And that might be a function of being in North Carolina, where everyone has grown up on sweet tea, and it really is a culture to sweet taste. But I don't know of any health benefit from having these other sweeteners, so that eventually I want to get those people off those sweet things too.
Yeah, I think I really congratulate you on your book, especially, and I'm glad to hear that you're working with Vera Tarman. and getting more knowledge about addiction. And I think the big trick is to, once you stop, how do you stay stopped? And that's where we talk about recovery protection, what most people call relapse prevention, but we think you really have to have a plan for yourself if you're truly an addict. Dave, where are you at? Well, Donna, go ahead and ask your question.
Yeah, go ahead, Donna.
So I can't hear. I think you're still
You're muted.
Yeah.
Yeah.
Oh, it would help if I unmute. Sorry. Thanks, Dr. Westman. Can you hear me now?
Yes. Yes.
Me?
No.
Oh, okay.
Yeah.
So thanks, Dr. Westman. Can you hear me?
It kind of goes in and out. It's
Hello?
weird.
We can hear you, Donna. I can hear you anyway.
Yeah, I can too.
Okay. Oh, you can. Okay. So I was just saying thank you for coming today, and thank you for all the work that you've done over the many decades. You're certainly a pioneer in this this keto world, and I've been following you for a while. Kind of touched on this, but I have two questions. What suggestions might you have as far as making this a forever lifestyle and not just a diet that one goes on and off? And then the other one was, what characteristics have you seen in patients that have had to adapt this way of life versus someone who goes on and off it? Is there certain characteristics that you see in people that are determined to make it a lifestyle? Thanks.
Yeah, great questions. And the first thing that comes to mind, that if I can help someone fix a medical problem, if I can help them get off medications, if I can help them get off insulin, they're going to be more wedded to the idea of doing this a while. So actually, I've come up with a way of explaining, have you ever had a doctor really ask you what you eat and drink? And they'll say, well, no. And I show the list that I just asked them to fill in. I asked extensively what they eat and drink. I said, well, that's right. So doctors don't ask you what you eat and drink. They diagnose you with things and give you pills. There's a pill for every ill, and then there's a shot. And that's one way to do it, but that's not what I do here. And so you explain that there are a lot of ways to go about things. It's, what I'm doing is basically having people make up their own minds, right? I can't tell them that this is going to be a lifestyle change that they'll do forever, but I lead them down that path that you won't need to have medicines and have control over so many different things. So my pitch to whether it's a lifestyle change or a short-term thing really depends on the situation that the person is presenting me with. So if they have no awareness of sugar addiction and they don't even know why they're in my office, I don't really bring up the idea that this is a lifestyle change forever. That's going to scare them away. So it kind of, now the other, I tried every diet, I would go on and off, and I said, well, then, this really has to be a lifestyle change. So it really depends on the person, how I approach it at first, of whether it's a whole, one metaphor I'll use is, I'm bringing you in like in an airplane for a landing, and then, when you get to the goal, the airplane's landed, you can decide what to do. This is a method to get to a goal, and I explained that I can use prescription strength diets, I can use prescription strength medications, and sometimes about 5% of my patients use phentermine to control cravings because they can't get all the carbs out of their life for some reason. And then there are programs you can purchase from doctors, where the OptiFast, MetaFast, Robard programs, which have a role to play. It's not my favorite thing to do, but I explain there are all these other things, and why not? Let's just try tackling it with food alone. You don't have to buy products, you don't have to purchase things and have surgery, that sort of thing. And so the initial kind of pitch of, let's talk about food, and then you don't need medicines. If I get people off medicine, they're feeling better, they're very likely to have it stick. If someone comes in the mindset, all I want is phentermine because they've been on it before from another doctor down the street, they're a little harder to get to convince that you can really do this without any medicine at all. And I don't get 100% adoption of the or incorporation of the idea that this is going to be a lifestyle change. But I think the more serious the issues that have been fixed, the more likely people are to stay with it.
Thank you.
You know, in terms of, you mentioned personality or other factors, have you noticed some people come in very happy with just eating eggs and maybe a burger, no bun, and then some chicken, and then other people come in and they want recipes, they want meal plans, they want something new every day. They want, you know, and you're pushing, I need more recipes. I'm like, look, there's this thing called the internet, and I point them to certain recipes. Linda's Low Carb is still a great website. Linda's Low Carb website and recipes. It's old school. You don't add in oils and butters and things like that. But the idea. So my tactic in terms of managing the food is let people find their own food, their own way of cooking things. So then I don't prescribe a certain way of doing it. But it's easier if someone comes in satisfied with fewer items than the I need something new every day. It's boring. Well, in fact, there was a psychologist who gave a talk from experience in a low carb program, and he said, if someone's missing food or they're not satisfied, it's really just the sugar addiction. It's really the sugar calling them, and they're not going to be satisfied until they get over that hurdle. I thought that was an interesting perspective. And then there was another friend, a doctor of mine, who worked in one of the residential programs here at Duke. You may have heard of the rice diet. The rice diet actually was at Duke. It no longer exists, but it put Duke on the map years ago in the 1930s. And it really was rice, fruit, and fish, but it was only 600 calories of rice, fruit, and fish for the day. So it was an ultra low calorie diet. The doctor who worked there later said, you know, some people come in here, you put them on a diet, the first thing they want to do is get off the diet. So the personality of, you're always trying to find the edge, the limit, like, right, you know, here's the limit of the screen. Well, can I have this? You know, can I have that? You know, can I go? Well, that's dealing with just the personality, and the approach I use is one sheet of paper, and I'll say, you know, 10 times in the video I ask people to watch, you have to stay to this list of food. You have to stay. If it's not on the list, you can't have it. So it's providing that structure for the food that some people will find helpful. It's a simple way to teach. And yet some people will want to find the edge of it and then, you know, fall off. And so that's why we need individualization of programs by people like you and me for folks, and being there to help support. You know, another metaphor we've used, I was talking to Sue Wolver, who is a physician in Richmond, Virginia, started a practice like this. She's awesome. And I say, you know, well, it's like teaching you how to ride a bike, you know, and you know, you might fall over and, you know, you get back up, I'll be your training wheels. And then when you learn to ride the bike, you don't need the teacher anymore, right? I mean, you're on your own. And but then Sue brought up, that's not the case for a lot of people, especially sugar addicts. It's more like learning to play piano or learning to play an instrument, where some days, you know, you just got to do it every day. Some days aren't going to be so good. And even, you know, some days you're not going to be practicing, but it's going to take time for it to settle in. And so then that's kind of the extremes of the teaching. For some people, it is like learning a little bit every day. So what we do as teachers is role model. Well, it's going to be okay. You know, if you've ever played an instrument, occasionally the teacher will play the piece that you're trying to learn just to show you what it's going to be like, role modeling how you can be if you keep practicing this way. But I like the bike riding metaphor better. It's easier and simpler. And I'll never forget the look of my kids' face when they learned how to ride a bike. I mean, they were gone. You know, they didn't need me anymore. You know, but careful if you use those metaphors, because I was talking like this with someone, and she looked up at me and said, "Doc, I never learned to ride a bike." So, so anyway.
Go ahead,
Thank
Barbara.
Yeah, Dr. Westman. So I have a family history of diabetes, and I reversed my own pre-diabetes with low carb, and I have normal fasting insulin. However, when I wear a glucose monitor, if I eat even a small apple or half a sweet potato, I get a spike of 60 or 70 points. So I'm thinking that's probably insulin resistance. I'll probably have it the rest of my life. I'll probably need to do either keto or low carb the rest of my life because of my genetics. I wonder if you comment on that.
Oh, well, no, that's normal. That's what happens to people when they eat carbs, is their blood glucose goes up. You know, unless you have a super fast and hyper response from your pancreas, Well, so, and this is fascinating because if you can imagine, so you have someone not eating carbs, they go in for a glucose tolerance test where they eat some sugar, they take a blood glucose and an insulin over time. That someone who's been keto adapted, meaning not eating carbs for a long time, they have a very slow response to the blood glucose. So actually, because the pancreas isn't used to pumping out insulin. I mean, this is the rationale, the reasoning, or the explanation. So that so actually your observation may be correct. When you're a carb eater all day long, or most days, or have a friend put on, you can test this yourself, have a friend put on, or you eat carbs for 2 weeks. I'm sorry, I don't want you to do that, but if you really want to know it yourself, go back eating carbs for 2 weeks, your insulin's going to go, okay, I'm ready for the carb now. And you eat the apple and it doesn't go up so much because your insulin went way up to keep it down. Now, so what I'm trying to say is the glucose response isn't the only thing happening. And what you don't want is that insulin response. So you're falsely reassured that, oh, my blood glucose didn't go up as much, but at the expense of the insulin going way up. So my answer or recommendation is get rid of the glucose monitor. Just don't eat carbs.
Thank you.
Does that make sense? I mean, so Dr. Atkins was the first one that taught me, 25 years ago, that if you do a glucose tolerance test on someone doing the Atkins diet, it's going to be falsely elevated and look bad. You got to refeed carbs for 2 weeks to get your pancreas, back in order to secrete insulin, and then you'll have a quote normal response. But it's the wrong test to do, because I don't want you to eat carbs at all. I don't want to know your response to carbs. In fact, Dr. Volek at Ohio State years ago said what we really need is a fat tolerance test. Now, what do you mean? What? We do glucose? No, glucose isn't the issue, and it's fat and ketones. So and imagine for the last 30 or 40 years, no one has ever measured a ketone level, right? I mean, you couldn't even do it. Everyone was focused on glucose. So I could envision 20 years from now, maybe we're all going to be talking about fatty acids and glucose in our, fatty acids and ketones in our blood, and we're not even going to measure glucose because nobody's eating carbs. Okay, maybe that was a little too mind-blowing. So
I posted Dr. Kraft's book in there, The Diabetes Epidemic in You, and he talks about hyperinsulinemia, which is what Dr. Westman is talking about right now. And that's really a dangerous thing, because that just shoves sugar into your cells. It's like hiding your sugar. And it's basically, if I can speak English language for you, your cells are supposed to have glucose, and it's like a perfectly coated sugar donut. I got this from an endocrinologist when I was a nurse. And he said, every time you dip that, your insulin goes up and shoves that sugar into the cell. It's like dipping that cell into a sugar again. So your sugar donut's like a perfectly sugar-coated cell. And then that sugar coats it and it gets harder and harder. And this is what's starting to happen to your arteries. This is why you lose your vision, you get neuropathy, all of these things. This is glycation, the sugar coating of your cells, and insulin drives that. So it's insulin kind of is like the quiet on the down low thing that we're not thinking about, but people are thinking about that more and more now. So, and the name of his book is End Your Carb Confusion. I had somebody ask, so End Your Carb Confusion, and it was written with Amy Berger as well. Edie.
Hi, Dr. Westman. I was at your ADAPT conference in Atlanta on the 19th of February. It was fantastic. I brought my husband, and I feel like I owe you a big thanks for a number of things, but one is that we've known for about 4 years when we first got a genetic test based on some blood results that he was having, some family history, that he is APOE44. So we've known for a long time he needs to be keto, and I'm a registered dietitian, and he wouldn't listen to me, but he's now listening to you. So thank you. Sometimes, it just takes external voices, and he just really enjoyed the conference. It was so good. Amy's talk was just outstanding too. So I have two questions, one for me, one on him, very unrelated. We just got his first blood work back. He's been like basically on the 20 gram of carb, or so since the first week of January. And so he just had that blood drawn actually on the 18th of February. So maybe 6 weeks in, and his testosterone had dropped pretty significant amount. We see a functional medicine doctor in Atlanta, and she wants to put him on testosterone. So I'm just curious, is this something that might be a temporary adjustment. What are your thoughts on that?
Well, does he have more
You've
weight
seen
to
that?
lose?
Yeah, it's an abdominal, not a whole lot.
Yeah. So honestly, I never measured testosterone.
Oh,
So I can't think of really any large data set of low carb or keto studies that have looked at testosterone. Um, in general, with weight loss, testosterone gets better, and I wouldn't use testosterone unless there were clinical symptoms. So
yeah, he is experiencing a lot of fatigue, and so we're both a little bit like, wait a minute, we were expecting the opposite because he had fatigue before, and so we just really felt like after getting fat adapted, his brain would be kind of coming online a little more in terms of energy, that he gets a severe dip late afternoon and he just kind of glazes over. And
so salt,
yeah,
sodium and salt.
okay.
Not
So
just
we do that
water.
in the morning, but maybe we need a second, glass in the afternoon.
So
Yeah.
in a clinical population, you don't push salt if there's heart failure or renal failure or
Right.
blood pressure on medicine.
Right.
People
Yeah.
monitor. But
Yeah.
The afternoon low, try a cube of bouillon in hot water twice a day. Most people will focus on something else because this is classic in a lot of the teaching. When you go against something that someone's heard for 1,000 times and you say it once and you think they're going to follow you, so I'll say have more salt and they'll come back. I'm tired. Well,
Okay.
Did you have more salt?
Wow.
Well, no, I didn't have more salt. Well,
Even
why
more.
not? I told you. Yeah. Well, the doctor so and so says you should. I've heard 1,000 times I'm not supposed to have added salt. Anyway, I'm not saying you won't have added salt or your husband won't, but just in general, when you give
Yeah.
a recommendation that's gone against what someone has heard, it's going to take people. Actually, they're going to see if you have a consistent message. And I use this with my car mechanic because I don't really understand how cars work anymore. And so if I just say, go in, is it fixed? How much do I owe? And when he starts going through, well, we did this and that is, look, I don't know. But I'm looking at him to see if he's like hemming and hawing and giving a consistent message. So when someone doesn't really know and you're new as the teacher, you don't have their trust yet. You just give a consistent message, but you'll know within 15 minutes if it's the salt, causing the low energy. But then also, if you're a caffeine addict, if you use caffeine, and you change everything, including you're going off caffeine, keep that in mind because you don't have to go off caffeine. So
yeah, we've kept that consistent. We've been at like half calf for like a number of months before going low carb, so that hasn't changed. But we'll add a second glass of like we use Redmond's real salt and Celtic sea salt, and I use some electrolyte thing from Designs for Health as well. But
well, so
go ahead.
Here's just my view for 20 years of telling people not to eat carbs. Everything is better. I don't have to add testosterone, and I've never prescribed vitamin D in my life. These are all things that can make money for doctors and maybe temporarily can make people feel better. I've never prescribed a sleep apnea CPAP machine. I haven't had to. But if it's going to take a year to lose the weight and CPAP wakes you up tomorrow, it's a valid thing for someone else to recommend and get all that. So consider that perhaps you don't have to keep adding things to get better. Testosterone shots and all this stuff. And I can't imagine. I don't subscribe to the belief that our soil is just doesn't have any nutrients anymore, and you need to have supplements and all this. I'm not a big nutrient supplement guy, but I'm really strict about not letting people have carbs. And I often wonder that the folks who don't keep the carbs that low, people aren't in nutritional ketosis. They're adding these other things because these symptoms remain, and it's not until you really get rid of the addictive or the blood sugar excursions. So again, that's just kind of my perspective of. I think of me helping people by taking away things that are bad rather than having to add things to normalize them.
Okay.
Does that make sense?
No, it really does.
It takes 20 years, maybe it will be not as long for you, but for me, it took me 5 years to kind of go, man, this really works if people do it. I'm going to change my pitch to, if you do this, it'll work. Because one person came back and said, well, you said that it would work if maybe I wasn't sure that it was going to work. And, oh my gosh, have no doubt this will work. It will, but you have to do it, and you have to do it strictly. So
Yeah.
I'm very clear about that sort of message. How you define a low carb keto diet matters. And I use really a method close to what's called Atkins induction rather than a keto diet out there.
Right.
I've never asked someone to have bulletproof coffee, coconut oil. In fact, today I suspected the heartburn that was lingering in somebody was from coconut oil because she'd never had it before and keto caused it. I said, no, keto doesn't cause it. It's the additive that the MCT, the coconut oil, the bulletproof coffees don't do any of that mess. If you're trying to burn your body fat, don't drink fat. That's kind of my, again, that's if you're trying to accomplish weight loss or diabetes reversal, you don't want to be adding in calories through drinks, including fats.
Right. Thank you. Very much so.
Awesome, Dr. Westman. Thank you so much for coming. And the big thing I heard you say was that not adding, like subtracting. And I think that's such a huge, massive message for us, especially as a bunch of addicts, right? So like we've been living our lives like more different, better, more different, better, more different, better. And here you are telling us don't do that. So that's awesome. I love it.